Let us discuss the clinical anatomy of the choroid in detail. So, what is choroid? The choroid is basically the posterior part of the vascular coat of the eyeball. The vascular coat of the eyeball is basically known as the uvea. The choroid is thicker posteriorly compared to anterior. Now, the thickness of the choroid in the posterior region is about 0.22 millimeters, whereas in the anterior region, the choroidal thickness is about 0.1 millimeter. The choroid basically has two surfaces. It has an inner surface which is in close contact with the retina, and on the outer side of the choroid we have the sclera. The inner surface of the choroid is basically smoother and it is in contact with the retinal pigment epithelium of the retina, whereas the outer surface of the choroid has a slightly rough texture and it is in close contact with the sclera. Coming to the layers of the choroid from outwards to inwards, the choroid basically has a suprachoroidal lamina, also known as the lamina fusca. Then we have the choroidal stroma, which is mainly consisting of vessels, and here we have the halers and the Sattler's layer. Then we have the choriocapillary layer, also called the Roish layer. And then we have the bruchs membrane. This is from outwards to inwards. So as you can see over here, the outermost layer is basically the lamina fusca. Then we have the choroidal stroma, in which we have the Haller's layer on the outside, and on the inside we have the Sattler's layer. Then we have the Roish layer, also called the Choriocapillaris layer, and finally inside we, on the most inner aspect, we have the bruchs membrane, which are not labeled here, and of course the choroid on the inner side is in close contact with the retinal pigment epithelium of the retina. First, we will discuss the suprachoroidal layer or the lamina fusca. The suprachoroidal layer is basically a thin condensed membrane of the choroidal stroma. So what I mean to say is the choroidal stroma basically will actually condense together and form a thick layer on the outer side, and this thick layer on the outer side is basically known as suprachoroidal layer. The suprachoroidal layer will be actually continuous with the supraciliary lamina anteriorly of the choroidal of the ciliary body. Now, there is a potential space between the suprachoroidal membrane or the suprachoroidal layer and the sclera, and this potential space is known as the suprachoroidal space. Now, let us talk about an important clinical nugget regarding the suprachoroidal space. The choroid and the sclera are usually in close contact with each other, and this happens because of the intraocular pressure. Now, this makes the suprachoroidal space a potential space which gets created with the accumulation of fluid. Now, this fluid might be introduced either externally or internally, right? So, what I mean to say is normally the sclera and the choroid are in close approximation with each other, and usually this space, suprachoroidal space, does not consist of any fluid within it. Okay, now however, the sometimes what we can do is that this potential space can be used for drug delivery, and this route of drug delivery is known as the suprachoroidal route of drug delivery. Here the surgical approach basically involves an ab externo incision. That means we are going to make an incision into the sclera through outside, and this is called a sclerotomy, and then a catheter or a cannula is basically inserted through that sclerotomy wound, and then it is passed through this suprachoroidal space and reaching exactly the posterior target where we want to deliver the drug. So this is basically a potential space for drug delivery, and you can actually utilize the suprachoroidal route for targeted drug delivery. Now, these procedures actually carry the advantage of precise targeting and visualization, since the catheter can actually be guided with the help of a flashing diode also. Now, apart from that, a lot of new glaucoma devices can actually be placed ab internally. So, what do I mean by ab internal placement? It means that we are going to actually approach the suprachoroidal space from the anterior chamber. So, when we are approaching it through outside, that means through a sclerotomy wound, that is called an ab externo approach, whereas if we approach the suprachoroidal space through the anterior chamber, that is called an ab interno approach, right? Now, these glaucoma devices can also be placed in the suprachoroidal space by accessing this space through the anterior chamber, and a lot of devices are there. These devices include basically the micro stent placements like the eye stent, suprachoroidal bypass system, and many more. Now what these systems basically do, or what these eye stents do, is that these are actually placed somewhere here in the suprachoroidal space, and they basically act as a alternate drainage pathway of the aqueous from the anterior chamber straight away into the suprachoroidal space, bypassing the diseased trabecular meshwork. So that is one very important clinical nugget point regarding the suprachoroidal space. Now, this is actually an OCT image which is depicting the suprachoroidal space. Now, if you observe carefully between these two white arrows, you can see this light black color hyporeflective band. So, it is also called a hyporeflective band on OCT because it is black in color. So, that hyporeflective band on the OCT, which will usually be seen on your extended depth imaging OCT, not on the normal OCTs. Okay, so on this OCT, you will see this hyperreflective black band, and this is basically your suprachoroidal space. Now, another clinical nugget regarding the suprachoroidal space is the choroidal effusion. So, what did I tell you? That the suprachoroidal space is essentially non-existent. That means essentially there's actually a close apposition between the choroid and the sclera, and the space is actually kept empty and dry by a balance between the intraocular pressure, which is pushing the substances outside. So what I mean to say is that you have intraocular pressure acting externally, and then you have the hydrostatic pressure of the vessels which are present in the suprachoroidal space. So as we move ahead in this lecture, we will study how the ciliary arteries are actually present in the suprachoroidal space, right? The long and the short posterior ciliary arteries. So the hydrostatic pressure of the vessels which are present in the suprachoroidal space is actually kept in balance by the intraocular pressure within the eye. Now, because of that balance, usually the suprachoroidal space is essentially dry. However, whenever there is this imbalance in the ocular fluid dynamics, what can happen? For example, when you have hypotony of the globe, that means decrease in the intraocular pressure, then the suprachoroidal space can get filled up with the fluid, and fluid in that suprachoroidal space is actually known as the choroidal effusion. However, sometimes even the vessels can actually bleed within that suprachoroidal space, and when that happens, that is known as the suprachoroidal hemorrhage. Okay. So when we talk about suprachoroidal hemorrhage, basically it actually happens because of hypotony of the globe, and that can actually occur intraoperatively during a cataract surgery. So during a cataract surgery, what are some of the signs of suprachoroidal hemorrhage? You will see that because of the hemorrhage within the suprachoroidal space, this bulging of the choroids will be seen behind the lens capsule, and this will actually push the lens iris diaphragm forward, leading to shallowing of the anterior chamber. Also, the normal red reflex that we get from the retina will be lost. Apart from that, the hypotony, as we know, leads to suprachoroidal hemorrhage, but once there's effusion and suprachoroidal hemorrhage, there will be actually firming of the eye, or increase intraocular pressure. And you can see from behind the lens, there will be wrinkling of the posterior capsule because of the bulging choroidals from behind. Sometimes the pressure within the eye can actually rise so much that there will be extrusion of the intraocular contents through the incision that you have taken. So suppose you're doing a small incision cataract surgery, you can actually see spontaneous nucleus expression, iris prolapsing, and even vitreous can actually prolapse. Now, apart from that, hypotony can also be seen in a post-operative period, and this happens during a glaucoma surgery, post-glaucoma surgery. So post-glaucoma surgery, sometimes the filtration will be excess, and that will lead to hypotony, and that will cause suprachoroidal hemorrhage. And such a patient will present to you with pain in the eye, headache, nausea, with or without vomiting. Okay, and these symptoms typically appear and they become worse with Valsalva maneuvers. So Valsalva maneuvers basically are nothing, are those maneuvers which basically involve forced expiration against a closed glottis. For example, when you are straining or during defecation, or if the patient has a lot of cough, or sometimes they play certain sort of musical instruments. Okay, so those can also can also lead to suprachoroidal hemorrhage post surgery. Okay, and such patients will have decreased visual acuity, anterior chamber shallowing, loss of red reflex, increase in trochlear pressure, and they can also have vitreous prolapse into the anterior chamber. And obviously when you do a B scan, you're going to see this bulging of the choroids or the choroidal elevation on the B scan. So now moving back to our topic, and we are discussing the layers of the choroid, remember. So now the next layer is the choroidal stroma. So the choroidal stroma is inner to the suprachoroidal lamina, and it actually consists of the loose framework of collagen, elastin, reticular tissue, pigment cells and other cells. Very similar to the stroma of the iris and stroma of the ciliary body. However, you should remember that the major part of the choroidal stroma is formed by the vessels. And what are these vessels? The vessels are basically arranged in two undefined layers. So these are the outer hallus layer and the inner Sattler layer. The outer hallus layers, as you can see, basically is composed of larger diameter vessels, whereas the Sattler layer, you can remember it with a mnemonic that Sattler sits inside. So the hallus layer is outside and Sattler's layer is present inner to the hallus layer. The Sattler layer basically consists of intermediate size vessels. So the stroma basically has the hallus layer, the Sattler's layer, they together form the stroma. Apart from that, you have the connective tissue and the various sort of cells which are present in the stroma. So now this is actually an OCT picture which shows you the three important vessels that you see in the choroidal stroma. So the outermost ones, which are of larger diameter, seen here as hyporeflective circles, are the hallus layer. Then a little bit smaller or intermediate size are the Sattlers, and then the tiniest ones which are present very close to the bruchs membrane and the RPE are basically your choriocapillaries, right? So here let's discuss two important clinical nuggets. The first one is regarding the choroidal thinning. Now, what happens with age, and something that you see also in pathological myopia, where we have a longer axial length? What happens is that because of increasing age and longer axial length, you will see choroidal atrophy, right? So, this choroidal atrophy will lead to reduction in the total choroidal thickness or choroidal thinning. Now, when we're talking about the thinning, it is basically the thinning of the Sattler's layer and the hallus layer and not the thinning of the choriocapillaries. So what I mean to say is usually the choriocapillaries are spared or they're affected very late in the disease, and the first ones which get thinned out in the choroidal thinning are basically the Sattler's layer and the hallus layer. Another clinical nugget is with regard to the presence of pachychoroid. Now, this is a new term which basically means a focal or diffuse increase in the choroidal thickness. Now, as you can see over here in this picture, now before that, I didn't show you this. So in this picture, you can see only this part is the choroid. Okay, so this is actually a thinned out choroid that you can see over here, and then this is of course the white line that you see here is actually the choroidal and the scleral junction. So the choroid is quite thinned out in this patient. Coming to this patient, you can see this is the thickness of the retina, and look at the thickness of the choroid. The choroidal thickness is much more than that of the thickness of the retina, and this basically indicates the presence of a pachychoroid. Now, in the group of disorders known as the pachychoroid spectrum group of disorders, basically you have dilated choroidal vessels, and mainly the vessels which are dilated are the hallus layer. And these dilated big hallus layer vessels are known as the pachy vessels. Okay. Now, what these pachy vessels do is that they will actually compress the underlying Sattler's layer and the choriocapillaries. So moving on, let us move on to the next layer in the choroid, and that is the Rausch layer or the layer of choriocapillaries. Now here we have this rich capillary network that you can see here situated just below the bruchs membrane. Okay, and these are actually the smallest of the vessels. Now, important point regarding the choriocapillaries is that they have fenestrated endothelium surrounded by the basement membrane and pericyte. So this is quite similar to that of what you see in the ciliary body capillaries. The choriocapillaries basically are divided into these non-overlapping lobules, which are very much homologous to what we see in case of the liver. Okay, so initially it was considered that the capillaries are actually highly anastomosing and they form a single layer or a monolayer. However, the new concept says that actually you have these the vessels, which are the choriocapillaries, are basically arranged in the form of lobules, and each lobule basically does not contact or anastomose with the adjacent lobule. So we have the segmental supply going on within the choriocapillary layers. Now, important point regarding the choriocapillary is that although they are the smallest of the vessels present in the choroidal stroma, they usually have this wide caliber, and it is so wide that it can actually permit multiple erythrocytes to pass through it simultaneously. So normally in our body, if you see the capillaries usually allow only single erythrocyte or an RBC to basically pass through it. However, the caliber of the choriocapillaries is so wide that it can actually allow multiple erythrocytes to pass through it simultaneously. Now let us talk about the density of the choriocapillaries. Now if you would actually observe, the density of the choriocapillaries layer is highest in the macular area where the thickness is about 10 micrometers. However, as you approach the periphery, the density and the thickness of the choriocapillary layer will basically decrease. Now this could actually be happening because of the photoreceptors which are present in the macula, and those photoreceptors basically need a lot of oxygen, a lot of nutrition, and maybe that is the reason why we have the thicker density of choriocapillaries in the macular area. Now let us talk about the peculiar feature of the choroidal blood flow. Now, it would actually be very interesting to note that the choroid basically receives 65 to 70% of the total ocular blood flow. However, although it receives a lot of blood, the rate of oxygen extraction is only 3% per ml of the blood flow through the choroid. In contrast, if you see retina, the retina basically receives only 5% or even less of the total ocular blood flow, but the rate of oxygen extraction here is 38%. Right? So you can remember it as because choroid has so many blood vessels, it has the hallux, sattler, and the choriocapillary layer. Therefore, the total ocular blood flow is more in the choroid. However, the the organs, or we can say the part of retina which actually consumes a lot of oxygen, is basically the photoreceptor. And the photoreceptors, since they are present in retina, the oxygen extraction is greatest in the retina. It is about 38% despite receiving only 5% of the ocular blood flow. Now, if you think about other parts of uvea, the iris receives only 1% of the total blood flow, and the ciliary body receives about 10% of the blood flow. Now, this is actually a very important point. Since the choroid is actually receiving a lot of blood flow, a lot of ocular blood flow, it actually can act as a heat sink, and this is useful when photocoagulation is done on the retina, since all that excessive heat can actually be absorbed by the blood flowing through the choroid, and this excessive heat can get dissipated, and therefore the choroid is known as the heat sink of the eye. Now, another important point that you must remember is that the choroid, basically, the erythrocytes that are traveling in the choriocapillaries, they travel about 5 times more slowly through the choriocapillaries compared to the retinal vasculature. And this basically happens because of three main reasons. Number one, as I told you, the lumina or the caliber of the choriocapillaries is much more larger. The amount of blood that is actually flowing through the choroid is actually more, and also there's a lobular configuration of the choriocapillaries. The lobular configuration, I already told you what does it mean. So it is somewhat similar to what you see in the liver as well. Now, because of these three anatomical factors, large lumina, the large lumen, large blood volume, and lobular configuration, the rate at which, the speed with which the erythrocytes travel is about 5 times slower compared to the retina. Okay, now this slower speed basically helps in oxygen transport to the photoreceptor, which consume the highest amount of oxygen per gram of tissue in the entire body. And this is the reason why the rate of extraction of oxygen from the retina is actually more compared to the rate of extraction which is happening in the choroid, because it is from the choroid which is receiving the maximum amount of blood flow the photoreceptors are actually extracting this lots and lots of amount of oxygen. Now moving on to the another layer, or we can say the innermost layer of the choroid, which is in close proximation to the retinal pigment epithelium, and this layer is known as the bruchs membrane. Okay, now this bruchs membrane is also referred to as the basal lamina or the lamina vitreae. Okay, now this is basically the innermost layer of the choroid. It sits between the retinal pigment epithelium that you can see here and the choriocapillaries. Now, when you observe it under electron microscopy, it is actually a pentalaminar structure. That means the bruchs membrane itself has about 5 layers. Okay, so from inside to outside, it has the basement membrane of the RPE. So these are the RPE cells. These are of course the photoreceptors which are present in close proximation to the RPE. So the basement membrane of the retinal pigment epithelium form the innermost layer of the bruchs membrane. Then we have the inner collagenous layer. Then we have the elastic layer. Then we have the outer collagenous layer. And finally, we have the basement membrane of the choriocapillaries which are present external to the bruchs membrane. Right? So let us label this pentalaminar structure bruchs membrane. So we have the basement membrane of the retinal pigment epithelium. We have the inner collagenous membrane, elastic layer, outer collagenous membrane, and the basement membrane of the choriocapillaries forming the outer layer of the bruchs membrane. Now here important point is with regards to the elastic layer, the central layer. Now this elastic layer actually gives strength, it gives biomechanical properties to the bruchs membrane. Apart from that, it also gives anti-angiogenic function to the bruchs membrane. Now, it is important to note that this elastic layer is actually absent in the macula, and that might be one of the reasons why we see a more amount of neovascularization, that is abnormal vessels growing in the macula compared to the other parts of the retina. Now, this is a histological picture which is depicting the retinal pigment epithelium. So, these colored cells are the retinal pigment epithelium. Just outside that, the pink acellular zone is basically your bruchs membrane, and then just below that bruchs membrane are your choriocapillaries, and these bigger vessels are basically your hallux layer. Coming to important clinical nuggets, since we're discussing the bruchs membrane and it is present in close association with the RPE, we are going to discuss about the outer blood retinal barrier. So what is your outer blood retinal barrier? Now the outer blood retinal barrier, it basically means that normally the choroid, the amount of fluid which is flowing through the choroid, okay, it's not going to pass so easily into the retina. If it leaks into the retina, it will definitely lead to retinal edema, okay, and it will cause drop in the visual acuity. So there are certain structures which are present in the retina and in the choroid which are going to act as barriers to prevent the leakage of fluid from the choroid into the retina. And these are the bruchs membrane and the tight junctions between the RPE or the retinal pigment epithelium, right? So the retinal pigment epithelium have these really tight junctions on the apical and basolateral membranes which prevent the leakage of fluid from the choroid into the retina, and therefore they are going to relatively keep the retina dry. Now at this point, I would also like to ask you which structure forms the inner blood retinal barrier. Okay, so if you know the answer, give the answer in the comment section. So, coming to another important clinical nugget, and that is regarding the drusen. So, what is a drusen? A drusen is basically a small, round, yellowish white lesion. Okay, so you can see over here. So, these yellowish white lesions are basically situated at the base of the RPE, the retinal pigment epithelium, and the inner collagenous layer of the bruchs membrane. So this clinical nugget is basically with regard to the location of the drusen. So drusens, basically the material is proteins and lipid deposits. Okay, they occur with aging and they can also be seen in age-related macular degeneration. But the location is important, that they are located between the retinal pigment epithelium and the inner collagenous layer of the bruchs membrane. So, with this, we actually finished the clinical anatomy of the important structure of the eye, that is the uvea. So, we discussed in our first part on the anatomy of iris. We discussed about the anatomy of ciliary body. We finished discussing about the anatomy of the choroid. And now, let us briefly summarize the functions of the uvea. Now, the uvea or the choroid, basically, it acts as a source of blood flow to the ocular tissues, and here it is very important to know that the outer four layers of the retina, that is the outer plexiform layer, the outer nuclear layer, the layer of rods and cones, and the retinal pigment epithelium, they are basically going to derive their blood supply from the choroid. Okay, so your posterior ciliary arteries are the ones that are going to supply these outer four layers of the choroid. A very important point. Of the retina. The inner six layers of the retina basically are supplied from the central retinal artery and its branches. So that is again a very important point. The inner six layers are supplied from the retinal circulation, whereas the outer four layers of the retina receive their blood supply from the choroidal circulation. Apart from that, the second function of the choroid is the production of the aqueous humor. So we discussed about these ultrastructure of the ciliary body. So the ciliary body and the ciliary processes basically are responsible for the aqueous humor production, and therefore they are responsible for the maintenance of the intraocular pressure and in turn the maintenance of the eyeball tone and pressure. Apart from that, the ciliary body musculature that we talked about in the anatomy of the ciliary body, it has the ciliaris muscle, in which the circular muscle of the ciliary body basically helps in the accommodation. Also, the choroid or the uvea, because it has lots of blood supply in it, because it has so many channels, so many vascular channels, the Haller's layer, the Sattler's layer, and the choriocapillary layer, it basically acts as a thermal sink of the eye. Also, there are certain important molecules which are actually produced by the choroid, and one such molecule is the eicosanoids. These eicosanoids are basically the molecules which are produced by the enzymatic or non-enzymatic processes, and they are derived basically from the arachidonic acid. So they play a very important role in inflammation. Apart from that, the choroid also has some antioxidant property, and therefore it also has a protective function in the eye. So that was about the clinical anatomy and the functions of the uveal tract. I hope you enjoyed it, and if this video added some value to you and to your life, kindly subscribe to our channel and give this video a thumbs up. That's all for today. Thank you and have a nice day.